Hi, my name is Alex Cavayas, and today we're going to discuss weaning VV-ECMO. I do not have any disclosures. VV-ECMO's role is well established for the treatment of severe acute respiratory failure. However, the emphasis so far has been put on patient selection and optimizing initiation timing. The weaning process, on the other hand, has been mainly overlooked. Guidelines on weaning are mainly based on expert opinion. Unsafe liberation from VV-ECMO occurs in up to 25% of patients. Premature removal may lead to severe respiratory or hemodynamic instability and potentially injurious escalation in mechanical ventilation. On the other hand, delayed removal may result in unnecessary increase in ICU length of stay and increase the risk of delirium, ICU-acquired weakness, nosocomial infection, thrombosis, or hemorrhage. In this presentation, we will review the existing literature supporting the different steps of VV-ECMO weaning. The first step is monitoring native lung improvement. This can be done, as we will see over the next few slides, by tracking improvement in lung aeration, improvement in respiratory system compliance or tidal volume, by noting increased CO2 clearance by the lung or decreased CO2 clearance by the ECMO compared to the lung, and lower dead space fraction. Key parameters that are used in the literature to track recovery include tidal volume, respiratory system compliance, minute ventilation, Murray scores, mean airway, and plateau pressures. As you can see on the right side of the screen, respiratory system compliance improves progressively in patients that are eventually weaned, but stagnates or even deteriorates in patients that never get weaned. Lung ultrasound can also be an interesting tool to track lung aeration. It is calculated by summing up individual scores assessed through the sonographic appearance of the lung in 12 lung regions. Each region is rated from 0 to 3, 0 being a normal pattern, 1 being some B lines, 2 being multiple B lines, and 3 being frank consolidation. Lung ultrasound score is similar upon initiation of ECMO in patients that eventually get weaned compared to patients that never get weaned. However, it improves significantly in successfully weaned patients. A lung ultrasound score below 15 could predict successful weaning in one of the studies cited here on this slide. The main advantage of the lung ultrasound score is that compared to the measurement of static compliance, which also can be used to track improvement in lung aeration, it does not require suppression of spontaneous breathing efforts with heavy sedation or neuromuscular blockade, which is often undesirable during the weaning phase. The disadvantage is that it's operator dependent, and sometimes it can be difficult to obtain reliable images in patients with marked obesity or subcutaneous emphysema. Carbon dioxide clearance by the native lung can also be used to track improvement. CO2 removal by the membrane lung can be measured with a standard CO2 gas analyzer applied at the sweep gas outlet of the oxygenator. VCO2 of the native lung is measured with a standard volumetric capnometer. And the total VCO2 can be calculated by summing up the VCO2 of the native lung with the VCO2 of the membrane lung. Belliato and colleagues nicely described that patients that eventually get weaned from ECMO experience an increase in the ratio of the VCO2 of the native lung to the total VCO2. In other words, when patients improve, native lungs take more and more in charge CO2 clearance. Conversely, another parameter that has been used is the ECMO minute volume, calculated by multiplying the logarithm of the extracorporeal blood flow times the sweep gas flow. Hartley et al. Found that a lower ECMO minute volume, representing, again, that the native lung is taking up more and more of the work, could also predict successful weaning, with an area under the curve of 0.89. Lazari and colleague studied the ratio between the end-tidal CO2 and the arterial CO2. It is a simple marker of overall lung performance, which also represents the capacity of the native lung to clear CO2 efficiently. It is affected mainly by dead space volume, but also by the amount of venous admixture. It is highly associated with weaning success in their study, with an area under the curve ranging from 0.58 to 0.87. The optimal threshold to predict successful weaning was above 0.84. Once we've established that the native lungs are starting to improve, the next step is to start challenging the lungs. As we will see in the next few slides, this can be done with the oxygen challenge test or by progressively decreasing the ECMO support, or by trying to extubate the patients while still on ECMO. The oxygen challenge test, also called SILE test, measures the PaO2 response to transiently increasing the FiO2 of the native lung for 25 to 30 minutes and then performing an arterial blood gas. This is performed systematically daily in certain centers. Ideally, the extracorporeal blood flow should be minimized prior to the procedure to maintain a saturation above 88. One has to know, however, that this oxygen challenge test is heavily influenced by the extracorporeal blood flow, cardiac output, and the systemic oxygen consumption, and is thus not a perfect measure of native lung function. In studies that have assessed its predictive accuracy, PaO2 cutoffs after the oxygen challenge test above 225 to 240 could be used to predict readiness for weaning. Another way to challenge the lungs is to either do progressive reductions in extracorporeal blood flow and sweep gas flow over days, with liberation trials done only when the patient is on minimal support. Or it could be done by going straight to daily systematic liberation trials. A progressive reduction in ECMO support may allow for a more negative fluid balance and improvement in order to improve native lung function. Also, progressive sweep gas flow reductions may allow progressive loading of the respiratory muscles in spontaneously breathing patients. A more gradual decline in the PVO2 entering the lungs could help restore delayed hypoxic vasoconstriction prior to attempting a sweep gas off trial. On the other hand, daily systematic liberation trials appear to be safe in the few studies that have looked at it. The exact initiation criteria, safety limits, vary significantly across studies. In one before and after study that looked at the effect of implementing such a daily systematic liberation trial, found that this could lead to shorter ECMO and ICU stays. The duration of ECMO support went from 11 days before implementation of daily systematic liberation trials to 5.5 days after such a scheme was implemented. And the ICU length of stay went from 27 days to 18 days. Interestingly, most decannulated patients following implementation of such a protocol, after a successful SGOT, had a sweep gas flow over 3 liters, an FDO2 of 100%, and full extracorporeal blood flow before the trial was performed. So they were on full support, and they could be decannulated successfully. Other centers advocate for liberation from invasive mechanical ventilation before extracorporeal support. The rationale for this is that it could allow to minimize the adverse effects linked to mechanical ventilation, enhance participation in physiotherapy, and alleviate bronchospastic stimulus related to airway instrumentation. The risk, on the other hand, is patient self-inflicted lung injury. Sweep gas flow adjustments to manipulate respiratory drive may be more challenging in ARDS patients because of an abnormal drive that persists despite PaCO2 and pH normalization. In a study by Crotty and colleagues, an increase in sweep gas flow produced a significant reduction in respiratory effort in all bridge to lung transplant and COPD patients, but in only 50% of ARDS patients. So this is a subpopulation where such a strategy may be more challenging. Moreover, we can look at ECMO liberation scenarios in broad terms. And each strategy may offer unique advantages for each type of scenario. In some patients, we could anticipate a simple liberation. In such patients, daily liberation trials performed systematically may offer multiple advantages. However, in other patients with delayed recovery, recurrent respiratory failure, or having had already multiple failed attempts, where we could qualify the liberation as difficult, a strategy of progressively decreasing the ECMO support probably offers the most advantages. In some other patients, a prolonged liberation may be anticipated. In patients in which support is nearing or exceeding 1 month, it is probably useful to perform to go ahead with liberation from invasive mechanical ventilation before extracorporeal blood flow. These are often patients with low levels of extracorporeal support, which are required to offset increased dead space ventilation. This often happens in patients who are on a bridge to recovery decision treatment. Once we've challenged the lungs, the last step is to attempt a liberation trial. The most common way of attempting a liberation trial is to perform a sweep gas trial off. The sweep gas is turned off, and the patient is closely monitored for signs of failure. Signs of failure include desaturation, excessive efforts, or hemodynamic instability. If the patient develops signs of failure, it is considered a failed liberation attempt. If the patient does not develop signs of failure after some period of observation, then the trial is considered successful, and the patient can be safely decannulated. The rationale for performing a sweep gas off trial is that CO2 elimination is primarily determined by the sweep gas flow, while oxygen exchange across the membrane is mainly dependent on extracorporeal blood flow and the fraction of delivered oxygen in the membrane lung. But oxygen transfer is so efficient in a normally functioning membrane lung that even at low FDO2s and sweep gas flows, significant oxygenation occurs if the extracorporeal blood flow is maintained. Reducing the extracorporeal blood flow below certain thresholds results in blood stasis in the circuit, which increases the risk of clot formation. Turning the sweep gas flow completely off stops both oxygenation and decarboxylation occurring in the membrane lung without additional risk of thrombosis, as extracorporeal blood flow can be fully maintained. The procedure the duration of the procedure varies across centers. In order to select the optimal procedure length, we can base ourselves on multiple elements. Gannon et al. And Teixeira-Paradis et al. Described that the median time to sweet gas flow off trials failure was 4 to 15 minutes. So these main failures, they tend to occur very early on. But Alexandros and colleagues described that in patients that did not fail rapidly, more subtle signs of unsafe liberation began to appear around the 4th hour after SGOT initiation. And we'll look at these criteria in a later slide. Of course, if a patient develops overt failure criteria, the trial needs to be stopped. Most these criteria varied significantly across different studies, but the ones that I've listed here are pretty standard. So a saturation below 88%, an FiO2 above 60 to 65%, a respiratory rate above 30 to 35, signs of respiratory acidosis or hemodynamic instability should all result in stopping the procedure and considering the trial a failure. (81% of patients that had a successful 30-minute SGOT were decannulated in the study by Gannon and colleagues. In the study by Teixeira-Paradis and colleagues, similarly, 89% of patients who had a successful SGOT were eventually decannulated. Alexandros et al., interestingly, described that parameters at the 4th hour of the SGOT could predict unsafe liberation. So although patients did not develop overt signs of failure, like we saw on the preceding slides, they started developing some signs that could predict that if we went on to liberate them from ECMO, they would then need re-escalation or of support, or even to be put back on ECMO. So a tidal volume of above 7.8 milliliters per kilo of predicted body weight, a heart rate above 110, a ventilatory ratio above 2.3, or inspiratory esophageal pressure swings above 16, were all worrisome signs that were predictive of unsafe liberation in the study by Alexandros et al. If we take a step back and look at all the criteria or parameters that have been described in the literature to predict readiness to be weaned, we can see that on full ECMO flow, the ones that performed the best were the ones that looked at the ability of the lung to efficiently clear CO2. So a lower ECMO minute volume and a higher end-tidal CO2 to PaCO2 ratio had a good predictive accuracy for safe liberation. During the SGOT, as mentioned before, lower tidal volumes, lower heart rates, lower ventilatory ratios, and lower respiratory efforts were also very accurate in predicting successful weaning. So in conclusion, the literature on VV-ECMO weaning is mainly articulated around 3 steps. First, monitoring lung improvement. Second, challenging the lungs. And third, attempting a liberation trial. Serial assessments of parameters such as the lung ultrasound score or the respiratory system compliance, as well as the ability of the lung to efficiently clear CO2 may help track native lung improvement. The oxygen challenge test is the most studied method to challenge the native lungs, but it displays only moderate predictive accuracy and may not be a necessary step. This still remains a matter of debate. Liberation trials using the SGOT enjoy a very strong physiological rationale and widespread adoption. the most robust evidence available on weaning supports the predictive accuracy of specific parameters at the 4th hour of the SGOT: tidal volume, heart rate, ventilatory ratio, and esophageal pressure swings. Overall, there is emerging but limited high-quality data on VV-ECMO weaning, which calls for increased research efforts. So I'd like to acknowledge all the help that I've received from residents in systematically reviewing the literature on the topic. And with this, I'm happy to take any questions by email or by text messages. You have my information below. Thank you for the opportunity to present this conference. Goodbye.